All right, so thanks for tuning in to the Meadow Medicine Podcast. Today's going to be another conversation with Tracy and myself, you and me. And today,
Mike.
Yeah, Mike. So I think today we'll dive into SSRIs a little bit deeper. SSRIs come up in conversation a lot with our clients that are interested in exploring psychedelics, in particular psilocybin. And to have such a large number of people in the United States that are on SSRIs, antidepressants, and having the reactions that they do to psilocybin, which is a blunting effect, there is a concern. People are concerned about coming off. Some people want to come off SSRIs because they don't like being on them. Some don't mind coming off SSRIs to do psilocybin. So people fall in these different buckets. And I think maybe we could just highlight the state of affairs, how prescribed SSRIs are, what are the most common ones, what are the effects they have on psychedelics, and kind of give an overview of the SSRIs. So I know you've been learning a lot, and you've learned a lot already from your medical school training, but maybe kick it off with just your understanding of where we are today with the volume and effect of SSRIs on psychedelics.
Okay, I'll open up by, commenting on how commonly prescribed these medications are. And so I was just checking the statistics before we hopped on to make sure I was accurate about this, but it's about 1 in 10 Americans is on an antidepressant of some sort. Now, there are different classes of antidepressants. SSRIs, Selective Serotonin Reuptake Inhibitors, are the most common. And so but there are SNRIs, selective serotonin and norepinephrine reuptake inhibitors. There are atypical antidepressants. There's a whole host of antidepressant medications, but SSRIs are the most common. 1 in 10 Americans is on an antidepressant. And then what the most alarming statistic to me is that 1 in 5 women are on an antidepressant. And if you look at, there's another statistic I came across that really hit me, but 1 in 4 white women over the age of 40 is on an antidepressant. 1 in 4. Mm-hmm. So these are among the most commonly prescribed pharmaceutical medications. And what's interesting about them, they really blew up in the 1990s, and it was part of an exciting and attractive theory which was the chemical imbalance theory. Mm-hmm. And so it's just a very, I think it was attractive for a lot of people. And we recently spoke to a prospective client who reflected this also to us, that it no longer felt like a moral failing if you were experiencing depression or depressive symptoms. It's like, oh, it's my biology. Like I can't, it's not my fault. And so I just was born with a chemical imbalance or developed a chemical imbalance, and this medication can help restore that balance. And so it was very promising, and it was more of a biological mechanism for explanation for depression. And there was a huge, multi-billion-dollar campaign for educating the public about this theory and these medications that were available.
By the pharmaceutical companies, right? Not by the government,
Yeah. It's all privately, privately funded. But, a lot of money gets put into the research and development of these medications. And we had, several blockbuster drugs that came out of that. Lexapro, Zoloft, Prozac. Yeah. So a lot of people got put on these medications. And there is very little fully informed consent for having people get put on these medications. I mean, oftentimes you're seeing your provider, and it's not even, what's another interesting thing I've learned along the way is that the majority of antidepressants actually aren't prescribed by an MD psychiatrist. Most of them are being prescribed by other providers, whether it's nurse practitioners, physician assistants, the medication.
Like lower level expertise.
Right. I would say people who just are probably overall this isn't their area of expertise and specialty. They're more general practitioners oftentimes, or they don't have the oversight of an MD psychiatrist. And so not that there aren't, providers who can provide excellent care in that, setting, but it's just a fact. And we've spoken to many people who I will, who are seeking psilocybin therapy and they're on an SSRI, and I'll ask do you have any, who are you seeing right now? Who are your providers, who are your support? And they'll say nobody. And
how are they getting it then? They must get
that's what I ask. I ask that clarifying question. I'll ask somebody's prescribing you the medication, right? You have to get, yes. So I will ask, who are you seeing because you have to see someone to get the prescription refilled. And people are tired of doing that charade of just, it's basically showing up, and they'll say oh yeah, I see someone, they just filled a prescription. It's very cursory and the most pejorative way of looking at it would be you're a legal drug dealer. So so that's sort of the state of affairs. And what's interesting is these drugs have been on the market and widely prescribed for about 30, 40 years now. And it turns out they're not the miracle cure that we were all hoping they would be, that they were promised to be. And there are, like I said, there's a lack of informed consent when people go on these medications. These medications are never designed to be taken long-term chronically. They are not studied for long-term chronic use. They weren't originally. When you do look at long-term use of these medications, there's quite a few serious side effects when taking long-term, and they were never designed for that. They were designed, and when they did do clinical trials on them, to be taken in conjunction with therapy. That's not in practice how most of them are prescribed. It's just, here's the pill.
Is that right?
Correct.
Do people need to get them initially from somebody who knows what they're doing, or can you just start off the prescription from a nurse?
Well, most nurse depending on the state that you're practicing in, nurse practitioners or physician assistants can operate either independently or with the oversight of a medical doctor who's not always seeing the patient with the physician extender, the other provider. In practice, I think a lot of people are receiving these medications without that direct oversight.
Yeah. And I wonder what this process looks like in practice at scale. 38 million, some of the prescription volume is insane. The number I saw was 13% of Americans on these things. When you go and have a conversation, is it something where you think the establishment, the healthcare establishment, say the health system in this case, or the health insurance companies, are giving directive to the practitioners to say, oh, if a patient asks about this, then give them the prescription? Are they kind of like insurance shoulders?
Insurance companies don't dictate care in that way.
It'd be the health system, like the hospital.
I think the way to think about it is who's paying for care. It's the payers. And who are the payers? It's the insurance companies and the employers and the government. And so when you look at what care gets reimbursed and how it gets reimbursed, there's going to be financial incentives to deliver certain types of care in a certain type of way, because that's what gets paid and how it gets paid. And so in that indirect way, and do insurance companies influence care? Yes, because they can deny reimbursement for any number of reasons. And there's a whole, pre-authorizations are an issue, and, care that gets easily reimbursed is going to be what gets delivered. But there are all sorts of influences on the practice of medicine, whether it's the pharmaceutical companies and their marketing, or insurance companies.
Yeah, we're one of only a couple countries that allow pharmaceutical companies to advertise on TV.
And then, there's the direct advertising that's allowed. Yeah.
Yeah, I wonder how influential that is. What moves the needle? Is it foot soldiers that are out there pushing it to doctors? What they did with Vicodin, and that movement, and they had kickbacks and referrals and all that stuff, which seemed to be clamped down a bit. Or is it more the health system has an incentive to who has an incentive? Because it seems like. Yeah, I know, but to have these things be basically proven to be not effective for people, you would think, okay, everyone's like, well, okay, let's dramatically cut back the prescriptions, but that doesn't seem to be happening at all.
Well, I think it will back up about like claiming that they don't work or don't help people. So they do. I want to clarify, like these were designed to be taken in conjunction with therapy, and they were never designed to be taken for a long time. They were meant to be taken for 1 to 2 years max. And if you look at the clinical trial data, that's what's been studied. And for a certain subset of the population with a particular set of circumstances, do they help? Absolutely. I mean, you will find tons of testimonials from people saying they saved my life. And so I think if you are in acute crisis or you're just trying to function, that they can be a lifeline for so many people. But every time you go on them, you should be setting a plan for when to and how to come off of them. It should be used like, if you break your leg, I come from the field of orthopedic surgery, if you break your leg, you need crutches for 6 weeks or 8 weeks or whatever. And then there's a plan to rehabilitate you so that you can get your leg strong again, and then you ditch the crutches. Do we have patients who want to hang on to their crutches for too long? Yes. Yeah. And so much of my work was helping to give people the confidence and the plans for coming off of their crutches. And yeah, I think that should be the same philosophy when prescribing an antidepressant. There's way more education for providers. You started exploring all of the incentives. There's explicit incentives, there's implicit incentives, there's incentive. Every person who's participating in the healthcare system has an incentive. I argue that it's the patient's incentives that matter the most.
Yeah, I mean, they would be the ones to not want it. Right?
They're not, it's all about education. Comes back to, I'm a big proponent of education is power. And if you have the proper education, then you're going to make the best decision for yourself. And too many of us, necessarily have to outsource our education onto the doctor or to the nurse or to the physician assistant, whomever it is, and we're depending on them to have the proper education to make the best decision for us. Well, oftentimes when you're in 15-minute visits, 30-minute visits, they're not able to gather enough data to actually make the best decision for you. And so it really is incumbent upon the patient, upon the client, to do their own research or thoroughly vet the person that is prescribing or making the recommendations for your care. There's a joke that you get what you pay for when it comes to your doctor, your lawyer, your accountant. There's massive, this is just one, and people regularly discount services. They will fork over any amount of money for a certain product, but then when it comes to services, and especially when it comes to healthcare services, people are not used to paying for their own care, and that's a separate conversation, but I do think there are many incentives at play, and it's a very easy and an attractive solution to just write a prescription for somebody and say, here, take this, let me know how it goes.
Yeah, totally. So what's up with these studies about proving it's not effective? Say more about that.
Yeah, so this is really important data to parse out, and it's been fascinating over the past 2 years as this has become, I didn't set out to become an expert in SSRIs and antidepressants, but I'm just responding to the need that is coming to me because there are so many people for whom they're not working anymore, and they are really excited about psychedelics and psilocybin therapy. They want to give it a try. And the issue which you touched on at the beginning of this conversation was the risk of the blunting or diminishing effect of the SSRI antidepressant if you are taking it while exploring a psilocybin journey. And so anyways, I've been diving into and educating myself with the same intensity that I did studying for my orthopedic surgery boards, except now it's just so I can serve our clients better. And there was a fascinating study that showed that for mild and moderate depression, antidepressants, I think it was specifically SSRIs, perform no better than placebo in 80% of cases. Damn, that's crazy. So the benefit that people are experiencing, I don't doubt that people are experiencing benefits when they start the medication, but it's placebo effect. And it's not It's worse than placebo effect though, because these medications come with very real side effects. Physiological dependence, vast majority experience that I've spoken to are dissatisfied because they're experiencing loss of libido. Some people will experience weight gain, and then there's this phenomenon that is really challenging called tachyphylaxis.
Tachyphylaxis?
Yeah, fancy medical term for like the colloquial saying is called Prozac poop out, which I had come across in my studies, which was, I mean, like props to people who maintain sense of humor throughout all of this. But it's where the medication is no longer working and there is emotional flattening, numbness. A lot of people describe it as feeling like there's just like seeing the world in grayscale, feeling like there's a fog or a blanket on top of them. It's just, you're just dulled to life. And while your stress response is dulled, which is helpful if you're experiencing depression, anxiety, but your access to joy and pleasure and bliss and fun and creativity, all of that is dulled as well. And so, but what's challenging is like if you've been taking the medication for years, you've definitely developed a physiological dependence on it. And so if you were to try to come off, people will try to come off of these medications on their own, either cold turkey or tapering, and it's challenging because you will. There's a few different phenomena at play there when you're coming off of these medications. One is the physiological withdrawal. You may be experiencing withdrawal effects. Two, you could be experiencing nocebo effects, which is the opposite of placebo, which is...
Oh, you expect to feel bad?
You expect to feel worse.
Yeah.
And then the third phenomena is like, okay, is this relapse of your original, condition, or there's sometimes a rebound effect because your emotions have been dulled for years. Oof. Your sensitivity
it's like the dam breaks.
It's not so, I don't think of it as the dam breaking as like, I mean, I guess, sure, there could be repressed emotions over that time period, but I think of it as, it's like, you've always, it's like you've never walked around barefoot for a few years and you've always had like cushy shoes on, and then you start, like I ran in barefoot running shoes, starting a couple of weeks ago, and I'm like, ooh, my ankles are sore. These ankle ligaments that I haven't been using in this certain way are sore. And so you start to experience your emotions, your nervous system is just more sensitive. Right. And so it's like, I say it's like becoming an adolescent again. You're just affected by all of life more. You're experiencing more high highs, low lows, and you're learning how to navigate that and developing your emotional intelligence, your emotional maturation again. And it's not easy. And many providers will misinterpret that as a relapse of your original, condition.
Right. Put you back on it.
Yeah. And it's safer to put you back on it.
Yeah. Yeah, that's fascinating. And what do you think is going on? Like from a philosophical perspective, the presumption is that the experience of consciousness arises in the brain. That's the presumption. And that people say, I got to rewire myself, right? I have an imbalance. I was born with this imbalance. My mom thinks this way for sure. I used to think this way. Now I think it's different. But the idea is that we're a combination of tubes and pipes and wires, and we're like somebody made a mistake here. They put the blue wire and the red wire, and if we just go in there and tune it up, then we can fix it. And that seems to be the whole basis for the pharmaceutical industry and much of the medicine industry, although there's areas that aren't like that. But they look at the experience of your mind, how you experience pain or joy or emotions that come to you. You don't choose to have them, but they're created by the combination of neurons in our brain. So by going in there and changing the chemical balance, we can like tune things up. Why does that? Certainly there's an impact of consciousness from the brain, from manipulating parts of the brain. If you take a hammer and hit somebody in the head, like they're going to experience reality differently. But there's not evidence, it's kind of the hard problem of consciousness. There's not evidence really to show that it arises in the brain. It seems like that is a model that just doesn't seem to be working. We've been stuck on the hard problem of consciousness. This path of pharmaceuticals seems to be a dead end. Is that the right way to think about that? Is that how you think about it?
Well, maybe start by, for people who aren't familiar with the hard problem of consciousness, like what is the hard problem of consciousness?
It's trying to understand how consciousness arrives. Why am I conscious? Presumably you are. I don't know. You certainly look like you are. And we use that as like a proxy.
The experience of having an experience. How does that arise? At some level in the evolutionary process, we go from a rock, which some people would say even a rock is, if you're a panpsychist, is conscious, but at some level there's, fungi and then plants and then animals and then humans, and we recognize humans as being conscious, but
we assume they are because they look like us and we know that we are.
Right. And is it due to having a brain? Is it, from the brain arises our conscious experience, or is consciousness fundamental and our brains are like radio receivers that tune into I think that's more of an esoteric.
But I don't know. I just to like put it on the pin. It's like it's the core idea is that it's arising. There's a physical world out there, and that we're arising as conscious experiences within that physical world.
Yes, I see where you're going. That is a very esoteric thing. I think for most people who are maybe on an SSRI antidepressant and they just want to feel better, like that is. That gets a bit esoteric, just trying to explore consciousness. And people are interested in learning about that. I'm happy to dive into that. I think that to tie it back to your original question, the way that I conceptualize it is that we have top-down experiences of reality that inform our experience of reality, top-down processes, and that would be from our brain and central nervous system through our spinal cord to our peripheral tissues, and then bottom up. So from our periphery, the somatic is another way to think about it. The unconscious, we're not consciously aware of the cellular processes that are happening in our distal fingertips most of the time. And it's bottom up. And so whatever we're sensing in our periphery, in our peripheral environment, that then gets sent as signals up through our peripheral nervous system, through our spinal cord and into our brain. Our brain perceives, and processes that sensory information and then makes sense of it. And in that sense making, we will layer on top emotions and then meaning on top of it. So there's a whole, and then back to the top down, I think of top down as being sort of our core identities and beliefs and ideas, self-narration about ourselves, and the way that informs our biology, and then how our biology informs our sense of self. And so, there is I think of it as the industrial version of medicine that arise like humans have a habit of, at least within the practice of medicine, is we make the body into a metaphor based on the current level of technological process. And so with the scientific enlightenment, the age of reason that then led into the Industrial Revolution, and then just the age of machines, the human body became conceptualized as a machine. Mm-hmm. And so there's an input and there's an output, and it's a linear conveyor belt process. And it's a very simplified, reductionist conceptualization of health in the human body. Let alone how people experience themselves in reality, and I don't even know how you put consciousness in that framework really, other than it would just be maybe exclusively top down. I think, therefore I am.
It doesn't fit. That's
Rene Descartes. It's Rene Descartes philosophy. It's mind-body dualism, and now maybe I don't know if this is just the current phase that we're moving through in terms of our technological evolution, but we're in the age of the computer and quantum computing and just quantum physics. And so you start to see conceptualizations and metaphors of the human body as a quantum computer instead, which I think is a much more accurate metaphor for mind body that unifies mind and body and spirit. And it's there is no duality there. It's a unification. And that, of course, the way that we think influences how we feel and how our physical bodies manifest, and vice versa. You know, like there are bottom-up ways to influence our experience of reality, whether it's breath work or exercise or just the foods that we eat. And so, yeah, I think that, I know that the chemical imbalance theory has been thoroughly debunked. It is one of those developments in medicine that we used to have a saying when I was in med school that 50% of everything you're learning will become out of date by the time you graduate, which is always a very disempowering, deflating kind of thing, because it's like, it was so knowledge and information based and rote memorization that is like, what's the point of doing this? It's all going to be out of date. I want to be taught how to think from first principles and give me frameworks. And then that's how a physician should think, because the information is always going to be changing. You should just be a first principles thinker and teach people how to do that well. And then there's another saying that, science advances one death at a time. And so basically most people practice the way that they're educated. They don't, hopefully we're supposed to do continuing education. We're supposed to evolve. That's what drew me to this field in the first place of medicine. It's like, oh, it's constantly evolving, constantly changing. And I love learning. I want to be a lifelong learner. But the fact is that a lot of people fall, and I saw this as I was in training, a lot of people practice the way that they were taught in fellowship, and by their mentors, and they're much slower to update. Mm-hmm. And also in medicine, there's very much I would say like skepticism, like that is the default stance, to be skeptical of any new innovation in medicine. That's something that we're taught. And I think there's a healthy level of skepticism for sure to have in your practice. But I think with the chemical imbalance theory, we're in the midst of that paradigm change. Yeah. And what I say is like, why wait 20 years before standard of care catches up to this? I've already met board certified psychiatrists who say that they see, psilocybin therapy being the first line intervention for anxiety and depression, especially mild and moderate in the future.
How much skepticism do you see of doctors who are pretty unfamiliar with psychedelics, about psychedelics? Like, do they kind of get it pretty quickly? What motivates them? How skeptical are they today, you think?
You're talking about just doctors in general? Mm. It's hard for me to say. I mean, I have had interactions on Twitter and X with people who are very skeptical about psychedelics. And I think, there's a few people who come to mind. And I think that for a certain subset of psychiatric patients, psychedelics are not going to work for them. It's like psychedelics are not meant for people who are schizophrenic, who have psychosis, who have bipolar disorder. Like, that's all to be determined what the applications of psychedelics may be within certain severe addiction and substance abuse. Like,
sure, for the vast majority.
Yeah, for a lot of psychiatric patients, they're not going to be a right fit. But for the vast majority of people, I do think that antidepressants are overprescribed. They became the default solution for so many people that they aren't a good fit for, and that I think that for a lot of physicians, they do see that.
Like, what's their mental model for this? Because it's like they have the mental model of SSRIs, which is like the brain, as you mentioned, is a sea of chemicals and neurons, and we're going to go in there and tinker with things. Okay, well, that didn't work. Psychedelics, it's another thing you eat. Psilocybin is a mushroom. You ground it up and you put it in your mouth. So you could put it in a pill form. So it looks similar. It's that kind of thing. How are they? I would imagine the inclination by default is, let's look at how it's interacting with the brain. It's doing something different, right? Maybe it's not interacting with this neuron, or it's this one. And so is that how doctors initially think of it? Because the experience of psychedelics is what is the healing part of it. It's not the tinkering
We don't
with my
know
brain
that.
part.
Well, I'm going to push back. We don't actually know that. We don't know if it's the journey experience that is leads to the therapeutic benefit. And people, in fact, are exploring that. Like, is it just the increased neuroplasticity that's available with psychedelics that leads to enduring benefits? And so
The idea is you could have a trip without having a trip. Like you could have is that possible?
that's definitely being explored right now. And that's a big, favorite, I think one of a great topic of debate within the psychedelic field. I tend to think, I think for a certain set of people, again, let's take, Parkinson's patients or anybody with a true neurodegenerative condition, Alzheimer's patients or anything like that. Like, do I think that there's a benefit to psychedelics that is not contingent on the journey?
Yeah.
Yes.
Yeah.
But I think for a lot of people, the journey session itself is therapeutic. And I'll give you the reason why. The reason why is because we are narrative-based creatures. That's how we make meaning. And that's part of the top-down process, is that so much of within our consciousness and our consciousness, and then what we're aware of, and then the subconscious set of our psyche, and then there's the unconscious. If we're looking at the framework that Jung popularized, because we understand ourselves through narrative and through story, we're a story based creature. That's how we conceptualize reality, is the hero's journey, the mythopoetic experience of reality. Because we are that kind of creature, understanding ourselves through story, which the journey experience definitely helps you with, is, I believe, a core part of the therapeutic experience for a lot of people, where it's our story that we've generated about ourselves in reality that could use some updating, releasing of limiting beliefs and our thoughts about reality in the world that we inherited as a child, and updating those beliefs and that construction of reality. Yeah, that's what I think about that.
Yeah, I like that. So I'm almost like, I think of it as you're inhabiting this position behind the driver's seat. You're in the ether behind what is the contents of the consciousness, and the ability to retell the story or rethink about the story in a different way totally shifts it from a tragedy to a comedy. And these things sometimes aren't that far apart. Like being really excited and really nervous is it might be like a slight tune of a frequency.
It's the story you tell yourself about it.
Yeah, and both are true oftentimes, but you don't have control in your waking life to make that switch. So
I would argue you can train yourself to co-create your reality intentionally, so that you can have more experiences of excitement rather than nervousness when you're getting up onto a stage, for example, to speak or to perform or what have you.
Yeah. So wave a magic wand, like you have every doctor in the country listening. Where SSRIs, like, are they, should we really be trying to wean people off them aggressively? And then certainly there's some people that benefit from it and yada, yada. But for the vast majority of people, the 40 million people or so that are on them, 95% really should be off them. And
I would hesitate to put any firm numbers on any of this.
Say vast majority.
This is where you and I differ. Is the physician in me is much more and the scientist in me is I even feel like I'm not a true scientist, because I am more we very much cage the way that we speak into a very balanced way of the likelihood and probabilities and all that kind of stuff. And I hesitate to use extreme language the vast majority of people should aggressively be coming off of SSRIs. No, I am not going to say that. But for the people who are interested, for the subset of people for whom SSRIs aren't working, and you're experiencing side effects, those are the people who are seeking out psychedelics in the first place. If your SSRI is working well, you're not depressed and anxious, and you're living your best life, and you're not experiencing side effects, who am I to say
for these people that want to explore consciousness, they want to go deeper into the existential reality of life. Maybe I would say
that most most of the people, for the class of patients and clients who are on SSRIs and want to explore psilocybin therapy, they're actually not doing it for consciousness exploration. They're doing it because their med isn't working. They just want to feel better, and they want to get access to their full spectrum of emotions. And so, and they're ready to do the inner work of not shaming or guilting themselves with the so-called negatively valenced emotions that they couldn't handle before earlier in life. And they're probably further away from the crisis moment that initially spurred them to take them in the first place. Whether it's oftentimes when I always ask people, like, oh, what were the circumstances like in your life when you decided to go on it? And it's always tied to some crisis, like whether in loss, whether it was the death of a parent, a loved one, you lost a job, a divorce, like these like crisis moments in life. And you reach out for help in the way that you think you're supposed to, which is asking your doctor. And this is what you got offered. And you're just desperate for help and just to feel better and to function. And so you do it.
So tapering is necessary because blunting occurs with psilocybin. So if you were to take an average dose a person would take that's not on SSRIs.
Let me clarify that. Yeah. So there's so much education around this piece because it's so not well understood, and we still don't understand it. So this is a developing thing because how long have we been giving people psilocybin with, legally, like literally starting 2 years ago. We've served more people in Oregon in the legal framework than all of the clinical trials combined. So I say that to point out that there have, like, when you look at clinical trial data and then extrapolating out into the wild, into the general population, like we're going to be learning so much in that second phase of applying it to the general population. I always tell people, keep in mind that when you look at the tremendous outcomes that we see in the clinical trial data, that those are in people who are not on antidepressants.
Yeah, they screen them out, right?
Yeah, they've been cherry picked, there are certain trials where they took people off of them first, and so we don't have good data to reliably predict what the experience and outcome will be for people who are on antidepressants. And then even then, it's like, well, which type of antidepressants and how much, and are they taking for how long have they been on them? And it's still such an individual thing. I will say that anecdotally, if we want to come up with a hard and fast statistic, it's about maybe it's not guaranteed that if you're on an SSRI, you won't launch and have a psilocybin experience or go on to receive benefits from it. But it's about maybe a 1 in 3 chance that you won't launch and have an experience whatsoever. Maybe there's a 1 in 3 chance that you have an experience, but it's diminished. It's not as full, vibrant, full technicolor and vibrant and emotionally evocative as a psilocybin journey would be if you were not on anything. And then there's a chance that you have a very transformative journey. And it's just hard to predict. And when you look at the investment that one makes when preparing for a journey and having a journey, especially in the legal setting and all of that, the question of optimizing oneself before the journey, that's always that becomes the next question. It's like, what should I do? Should I come off of my med? Should I taper off of it? For how long should I be off of it? And so I say to that, most people are coming to us. They're coming to us for a reason. It's because they're dissatisfied with the SSRI and they want to come off of it. And they either don't have support or guidance. They maybe tried to do it on their own and they weren't successful. They're worried and scared about the challenges that would arise and not sure if they can do it. But the desire is there. And so if the desire is already there, then I say that it's incredibly motivating to persevere and to build some resilience in the process of tapering if you have a goal of, hey, this is optimizing me so that I can do the real deep inner work with the psilocybin. And so it is a wonderful opportunity in preparation for a psilocybin journey to take that as motivation to taper off if you already had that desire anyway. And then And then it's just a question of how quickly do you want to taper? How long, do you want to take to taper?
Numbers? Like throw some numbers out there.
Yeah, if you look at certain, and I've been doing a lot of study with this, there's something called the Maudsley deprescribing guidelines. There are some psychiatrists who are really pushing the envelope and spearheading this movement to this deprescribing movement. So there are physicians out there who are popularizing this. I've signed up for a workshop, I think next week, on learning even more about this. And I've helped clients do this as well, just with my own study. And there's wonderful forums out there where people are just taking matters into their own hands and deprescribing themselves, tapering themselves. There's one website called Surviving Antidepressants, wonderful resource, where people just share their experiences of coming off, what worked for them, what didn't work for them, how they did it, how long they took, what their their effects were. And so it's so individuals. I have clients report that they just did it cold turkey and didn't experience much of a withdrawal effect.
Wow. Do you think that's dependent on the SSRI?
It could be. Some are long acting and short acting. And so therefore some could be harder to come off of, and then, there's reports that the SNRIs are harder to come off of because of the effects on the dopamine system in addition to serotonin. And
is depression the most common reaction to going too quickly? Like you just feel low energy and...
I don't think that's the main side effect. That can be like low energy, fatigue, brain zaps is one. If you try to come off too fast, literally feels like an electric shock in your brain.
I've never been on SSRI, so a lot of this is just, I don't know how to relate to it in many ways. Like when you say that, I'm like... Sounds bad.
An electric shock in your brain. It tends to be correlated with movement. God. If you turn your neck too fast or too rapid an eye movement, you shock yourself.
Wow.
It's terrible. Try to function that way. Headaches, insomnia. And a lot of the tricky part is that a lot of the withdrawal effects overlap with depression, but then the brain zaps don't. That's a phenomenon that for a long time was not recognized by the healthcare professionals. No. Wow. And we discover all of this based on reports, and eventually we believe people when they're sharing it with us. But I would say that, the most rapid way to do it, I'm not necessarily recommending this, I'm just sharing what people share with me and what I've read about, is to do it cold turkey. And then, and I would say you'd only want to do that if you're in a stable period of your life, you have a stable living situation, stable job situation, you're able to tend to yourself and take care of yourself like you're in monk mode, where your sleep is dialed in, your nutrition's dialed in, your exercise is dialed in, you have good support, whether it's, somebody to be emotionally with you through that ride.
And with cold turkey means
you just stop taking it one day.
Why wouldn't, I would think you'd always want to do some kind of ramp.
I'm not making advice or recommendations about how to do this. I'm just reporting the different ways that you can do this.
Oh, okay.
So some people do stop cold turkey. Do I recommend it? No. Especially if, I think people tend to be more successful with that if they haven't been on the medication very long.
Oh, okay.
Even taking it for 6 months or a year or something like that. It's the longer you've been on it, the longer you're physiologically adapting to taking that medication. So you would presume that somebody who's been on it for 40 years would not do it cold turkey versus someone who's been on it for 6 months. And then of course there's the constellation of other things that you have to look at the whole person and be holistic about this. There is no one size fits all when it comes to this. And so the other end of that spectrum would be what's called hyperbolic tapering. So that is a very slow tapering process where you're tapering, decreasing your dose every 2 to 4 weeks. And then you're decreasing by a very small amount over that 2 to 4 week period. So maybe you're decreasing by 10% every 4 weeks. And then when you get to the very smallest dose, you're then, compounding in a liquid formulation at a compounding pharmacy so that you can literally decrease your dose. The last, a lot of people report that it's the last few, the smallest doses that become the hardest.
Oh, really?
Yes. Huh. And so, And so you might want to hyperbolically taper, say you're on Zoloft and you find it easy to go from 200 to 100 milligrams, no problem. 100 down to 25 was a little more challenging, but that last 25 coming down, like just jumping from 25 to 0 is too big of a jump. So what you can do is go to a compounding pharmacy, get a liquid formulation. It's more expensive, but you can then very slowly taper drop by drop, decreasing until you're eventually off. And I think this naturally leads into the next conversation I have with people, which is, which you might be asking about, which is how does microdosing play a role in all of this? And microdosing, I believe.
Microdosing psychedelics.
Yes, specifically. And I'm going to speak.
SSRIs. I guess that would.
Well, that would be hyperbolic tapering is microdosing. Okay, but the people ask me all the time, like, can I use microdosing to help me in this process? And I say, this is the one, the science on microdosing is not very good. It's not nearly as robust as the science behind macrodoses or large doses of psilocybin. And there's many reasons why the science is harder to do. I won't get into that, but I do, from what I have seen of the data, there is a special application. There seems to be a real effect for microdosing on people who have established diagnoses of anxiety or depression, or as opposed to just microdosing for optimization, creativity, and whatnot. But people who are experiencing anxious or depressed symptoms seem to have a real benefit from microdosing, more than placebo effect. And then I believe that it can be used specifically as a bridge therapy. And the concept of a bridge therapy is when you're transitioning from one medication off of, or like to being off of it, and there's a period of time when you're in the coming off of the medication where you're at higher risk for whatever. We do this all the time with patients who are going on anticoagulation. This is like post-op. You give them an anticoagulation medication to thin their blood to prevent a DVT or pulmonary embolism, and you can't send them home on the IV medication, and you want to switch them to an oral medication, but in that process of switching from the IV to the oral, they actually become hypercoagulable. So you have to introduce a bridge therapy to help in that process. Oh, wow. So anyways, that's the concept of a bridge therapy that a lot of doctors will understand. And so for patients or clients, it's the idea that you introduce the psilocybin microdose a few weeks when you're on that last, say, in the Zoloft example, the 25 down to 0, you introduce the microdosing to soften that landing. And then then you stop the Zoloft, you continue the microdose for a few weeks, and then it's much easier to come off of the microdose physiologically than it is the antidepressant.
And do you think psilocybin is the best for that?
I have no idea. Yeah, I think LSD. What I've seen, psilocybin makes sense to me in terms of the neuroregenerative properties that we know of it, and also just how physiologically safe it is and all of that. So I do think there is a role that microdosing can play as a bridge therapy.
It's also nice because psilocybin it's a mushroom, so it's presumably easier to access, and then B, compared to LSD, the volume of it is, for you to accidentally take twice of a microdose, like it's not going to be a big deal for psilocybin. But if LSD, like you can't even tell the difference. It's measured in microns. So the difference
micrograms,
micrograms, yeah. So the difference between like a big dose and a microdose is like you couldn't even be able to tell the difference by looking at them. Whereas like a big dose of mushrooms, you're like, oh my God, how am I going to eat all that? That's like a lot of mushrooms.
Yeah, it's definitely harder to overdose with mushrooms.
Yeah. It's interesting. I'd be curious to see. I guess difficult to study, but there's probably so much anecdotal evidence. And ultimately, it's nice to have a scientific researcher to go and do that process. But really, people just want to know, like, okay, realistically, what are the risks here?
I'm a big proponent of being your own scientist, and you are an N of one experiment. You arm yourself with the knowledge to proceed safely, and then give it a try.
Yeah, and microdosing psilocybin is pretty low risk. I mean, is there any side effect of for anybody taking
Yeah,
a microdose?
to have full informed consent with microdosing, it would just be like, could you experience headache, agitation, irritability, maybe some. And I say if you are experiencing that, you probably are taking too high of a dose.
Yeah.
And so it's supposed to be a so-called subperceptual. You don't have
Right.
any overt visual changes or, super increased emotionality or anything like that. It's just like a very subtle background lifting.
Yeah, that's a big misconception, I think. People
Yeah.
think microdosing, I'm like, it's like 2 drinks or 1 drink of alcohol equivalent. We're like, I'm a little buzzed, but
No,
it is
exactly.
subperceptual.
Yeah, and we could do a whole episode on microdosing. There's so much miseducation around
Yeah.
that, and like I just had to a comment on one of my YouTube videos about, I took 1 gram of mushrooms 4 days in a row, and I was like,
That's not
way too much, buddy. Like, and I can't give advice over the internet, but I'm like, just go watch my microdosing video and
that's great.
educate yourself before you just. It's kind of like our friend. I won't mention exactly who it was, but we were having a dinner conversation, and they just are just trying psychedelics without any. Without any enough education, and so you accidentally take too much LSD, and then you're tripping for 14 hours on a day that you didn't prepare for that. And so, I'm just like, educate yourself.
Yeah. Hence your video. Your YouTube is awesome because there's really not a lot of content out there on educational content for psychedelics. Yeah, let's peg that as the next conversation. Microdosing will be fun. Anything else on SSRIs here you think are important to put out there? We talked about the research on the lack of effectiveness, the history, the prevalence of it, the interactions with psilocybin.
I guess I want to flesh out a little bit more the interactions with psilocybin, just because it's such a nuanced conversation and helping people in that decision-making process for themselves. So it's technically safe to take psilocybin with an SSRI.
Right.
There is a theoretical risk of serotonin syndrome. That was the concern, but we just aren't seeing that in practice.
What is that? What is serotonin?
It's where you have too much serotonin in your system, basically. You have a flood of serotonin, and it's quite unpleasant. It's, and it could be dangerous in terms of, we see it when we stack multiple serotonergic medications. It happens in a hospital setting usually. So where you're sweating and there's cardiovascular changes and stuff like that. But
that's not a real.
We don't see that. Yeah, there are people who I've given psilocybin to people who are on an SSRI. I would say that while so you can take it. Is it optimal? No, because of the blunting diminishing risk. But for certain people who want to proceed, I think it's totally safe to do it, and you can try. And there are certainly a subset of facilitators who, if you're not in a position where you are desiring and motivated and you have the circumstances to taper off of your antidepressant, then they much rather just see what kind of benefit you can get from one journey. Maybe you increase your window of tolerance. Maybe you're able to make some progress on a few areas where you felt blocked, and then go through the tapering process with the idea of maybe doing a second journey after that. I guess my thoughts on that are, if you're not in a position in your life, you don't have the life circumstances to sustain the tapering process, you may not exactly be in the position to be taking a large dose of psilocybin because of the instability that is inherent in the process. It's a good instability that you introduce into your life. You're feeling stuck, so it's like that's the entropic brain theory. You increase some entropy into the system, some increased flexibility in the system so that you can rewire. You're actually moldable in that way. You can rewire things that increase neuroplasticity. And so you want relatively stable life circumstances in order to move through that process safely. And I also, another thing that has influenced my thinking on this is that it was a microdosing webinar that Robin Carr Harris was helping to teach and speak in, and we came to the topic of taking a psychedelic, or I think it was psilocybin specifically, in conjunction with an SSRI. And they're just fundamentally different paradigms, and in fact, in some ways, conflicting paradigms. And so it doesn't quite make sense on that theoretical level to proceed that way.
Sorry, to proceed what way?
To give psilocybin while someone is taking an antidepressant.
Okay.
So I'll explain why. When you're taking the antidepressant, the theory is that, it's theory and the way that we understand about it too. There's a lot we don't understand, but this is what we do understand. It dampens the stress response when you take an SSRI. Part of the problem is it's an inelegant solution. It dampens every response, your libido response, all of that, which is that's the unwanted side effect. And so it helps to dampen the stress response and dampen all your emotions. And so I say it's like when you feel like you're drowning, it's like strapping on a life preserver. Okay, great. You're able to you don't have to tread water anymore. You have this buoyancy that helps you stay afloat. At a certain point, when you get to a certain point in your life where you are willing to take on the deeper inner work and really explore the increased neuroplasticity and do the rewiring and all of that, participate in your integration, you have to take the life preserver off in order to dive deep. It's because while we still are elucidating the exact mechanisms by which psychedelics and specifically psilocybin are therapeutic, beyond just recreational exploring consciousness experiences, but in terms of helping people who struggle with anxious and depressed symptoms, or chronic PTSD or substance abuse, that sort of thing. Part of the therapeutic experience is the increased emotionality that helps you to learn. There's an emotional intelligence process there. And so if you have the life preserver on while you take the psilocybin, you can't exactly dive as deep as you want and need in order to experience the benefits that you're ultimately seeking. And so that's sort of just the nuance that I would like to provide there. And so, Robin Carter Harris is just sharing that, he doesn't think that makes a whole lot of sense. And I'm like, that doesn't make a whole lot of sense to me either, to try to give you psilocybin while on it. Now, Can it be part of a tapering process? Can we have a psilocybin journey in the tapering process? For sure. I think, why not give that a try? As long as people understand that it's not going to be, and I think most people understand it's not silver bullet, and it's not one and done. It's just part of a new modality where rather than thinking I'm permanently, I suffer this chemical imbalance and I'm permanently sort of malformed, that it's actually, no, I actually sustained a series of life events, whether in my childhood or early in life, that left an imprint on me that leaves me constructing my reality to experience it in a certain way. I'm ready to interrogate those base beliefs that I developed, that conditioning and the patterns that I developed, and shake that up a bit and intentionally rewire myself to be in a better state of well-being. And a psychedelic is a catalyst for that.
Totally.
So I think that's probably the last piece that I would add.
I like it. Sweet. All right, awesome. This is a great conversation. Peace.